Well, thank you for that, Laura. Good memory. We always want to remember to record our meetings for those who can't join us today, but thank you so much for those of you who have taken a few minutes out of your day to join us for this workshop. I'm really excited to learn so much more about the ever growing, I think, role of community health workers. Today, we're going to be welcoming Brenda Lee Rodriguez, a good friend and colleague, director at Chula Vista Community Collaborative located here in California with us in San Diego. And Aida Meza, who works with Brenda Lee as a care navigator and promotor. No, I don't roll my tongue quite right on that, but I keep working on it. I'll get it. All right, just a little bit about PFCC Partners before we continue, and I apologize if you're hearing a little bit of wind. I'm forced to be outdoors at this particular moment doing this workshop. So in any case, if you haven't spent your entire last year on Zoom, here's a few instructions for Zoom. So just so you know where everything is, we'd love for these conversations to be interactive. So if you have questions rather for our panelists today, please feel free to put them in the chat box and we'll do a little Q&A towards the end as well. If we can't get to them all during the course of our conversation today, we'll be happy to have our team follow up with you afterwards. All right, next please. So I see a few new friends on with us today. But welcome. My name is Libby Hoy. I'm the founder and CEO of PFCC Partners. We are a patient and family driven organization that uses our own lived experience and that of our PFA network members to reinvent the healthcare industry so that hospitals, healthcare organizations, and an ever expanding number of stakeholders continuously partner with you and I and people with lived experience navigating the healthcare system as a resource to the co-design for the policies, the practices, and the improvement that we all desire to see in healthcare. We believe firmly in partnership. On the next slide, you'll see that we also, PFCC Partners fully supports the PFA network. We are a growing community. I think I've used the term growing 3 times already, but this is the future of patient-family engagement. It is definitely growing. We are a growing community of people like myself who use our lived experience navigating the health system to partner in that role I just mentioned. We're just a little over 800 patient family advisors strong at this point. We are a sense of community there to learn together through peer learning and skills exchange. And also we like to be that connector. I often describe myself as a giant Lego. We like to help people who are using that lived experience connect with the health systems that really need to hear those voices. On the next slide, I think, I hope that's not my noise, Joe. On the next slide, I think we're passing right off to our wonderful panelists, Brenda Lee and Aida. And I'm going to let them introduce themselves, but just suffice to say, we are really honored to have the 2 of these ladies with us today. So with that, I'll pass off. Brenda Lee?
Yes, I am sharing my screen. I hope that you do get to see it. And I'm going to put it on presentation slideshow. If someone can just with a thumbs up.
Yep,
yes?
That's good.
Fantastic. So I'll be navigating the slides and with my colleague here. My name is Brenda Lee Rodriguez and I direct the Chula Vista Community Collaborative. We are a hub of organizations serving the community and across the San Diego County area. I just came from 20 years in Florida, and that's how I met Libby with our work at the Patient Centered Outcomes Research Institute in Washington, D.C. And here I got to meet Aida, and she will tell you more about her story and the work of Promotoras. So she has a dedicated time to tell us about her story. I welcome everybody today to this session in which we're going to present to you the model we have been working on throughout years. And not only in the current role, but expanding the role of the community health worker and promotor into care navigation. Many of you might be interested in learning more of that. We may share some new information or reinforce some information you already know. As we move forward in 2021, we do want to take a moment to recognize the lives lost to the pandemic in the last months and the countless numbers of people that have been affected in so many ways. And now with vaccination, hope is back. Our promotores and navigators, not only here, but across the nation, have played a public health role in this COVID-19 response with contact tracing, education, vaccination, outreach, education, and support to families and the communities in general. Now, we can continue to assist even more with chronic disease management and telehealth readiness and other support. And we will tell you that and share our experience. And for you to have a bit of a context of what promotores, community health workers are, we will tell you first, then give you some examples about the work in healthcare delivery. And of course, this is the big reason you're here, to hear the stories from the field, enhancing the patient voice as CHWs are advocates and patient themselves, front and center for healthcare. You may have heard the term. You may be asking, oh, what do they do? Do you know one? Maybe you are one yourself without even knowing. Community health workers is that umbrella term for many activities that are being done in healthcare systems, and I'll tell you more. First, I'm going to show you some of the pictures of promotoras and community health workers in action in the community, the frontline service. They do education one-on-one, as you see, using flip charts, using handouts, using product demos. They do intercept. So sometimes when we want to reach out to a particular audience, they go out where that audience is. I have had CHWs, as you see, they would outreach to women. So they will go to supermarkets, they will go to laundromats, they will go to public bus stations. They will also attend health fairs and provide that, not only the material and the education, but those 10 seconds that it takes for saying, oh, hello, my name is Maria. Here's a phone number. You can call me if you want to know more about. Those extra 10 seconds can make a difference with that warm welcome and smile to get people to seek help. And also we go there where, like you see in one of the pictures, we go to citizenship classes, English for adults classes. We want to go where the community, the intended audience is. And we participate in events. We participate in advocacy activities. There you can see me and my team with a topic on cancer and a local event. And we are there, visible always with the community. So as you see, we are frontline workers. Some of us are paid, some others are volunteers. Promotores de salud is a term that you may have heard in the past, but it is in alignment with community health workers, health navigators, outreach workers, peer educators, lay health workers, many terms, but the umbrella name is community health workers and promotores, providing a health education and support to community members, serving as liaisons between the social and health services and the established healthcare systems. And they are not necessarily are to be deployed like regular health department staff, but yes, they have been called to serve, like in this case we have seen with the pandemic. And one minus that is something we battle and struggle with is that sometimes, actually the majority of the time, the promotores are not permanently employed. They do depend on program by program, and that is something that we face on all the organizations that we employ community health workers. So a definition, so we all are on the same boat, and I'll share the one from the American Public Health Association that has a special interest group on promotores, community health workers, is that is a frontline public health worker that is a trusted member of the community with a close understanding because they are experiencing some of these diseases, conditions, and experiences of that community. There is a trust there because they serve as liaison, as an intermediary between the communities, the patients, their families, the advocates, and the health and social care systems. But they don't stop there. They aim to increase the health knowledge, literacy, and self-sufficiency of these populations so they can empower themselves and become more active in their healthcare. Something that resonates with many of you, I'm sure. And I wanted to share just quickly a visual so you get to see that in the healthcare. And this visual, I have to give credit to my colleague Venus Ginez in Texas with the Dia de la Mujer Latina. She puts it very succinctly there. All the roles that are located in the healthcare system and that CHWs connect with all of these categories within the healthcare system. And for you to know that the context of these workers is actually classified already in 2010 by the US Department of Labor as a trade. And with that classification, it comes reimbursement for services. So since then, we have had an official integration push initiative to bring them in healthcare. As you know, billing coding is important, a driver of change and of programs within the healthcare system. So that milestone in 2010 really make a difference because community health workers have been there since the beginning of times, and now more and more within government, especially integrated in CMS and Medicaid services, allows for that reimbursement for preventative service under the supervision of a licensed physician or other professional. We are there. So this means that CHWs and promotores and navigators really make a difference with equity. We may have heard the word equality and equity, and I think that, and I am a firmly believer that CHWs do make a difference with the fairness of equity. And this is visual. I really think that it depicts what equity is, that not everybody fits a mold, and we do have to make accommodations and tailoring services and interventions to help our patients and families within the healthcare system. CHWs make it happen. We have seen how CHWs and promotores have worked in service providing right there assistance with our families and patients. And this is a point that I have spent the last 7 years of working with integrating them into research interventions to learn and create more science, more information on new programs, because they are important in the creation of that new scientific knowledge with proper training. And they can contribute to the best practices of those interventions, as well as providing social justice by bringing up the voice of patients and their carers. In healthcare teams, that's the key word, teams. It's a team effort. Everybody has a role. And I propose, along with many colleagues across the United States, that the CHWs are connectors. We have seen some even integration models in states, and I list just a few about the impact that measurable outcomes, very solid, concrete results of interventions and programs that have included community health workers in several diseases and conditions. And we are experimenting, piloting, and creating more data that supports the integration of CHWs into the healthcare systems. I'll share one example with the cariño, and cariño in Spanish means like love, care, and that is what we provided in my previous position with an intervention of community health workers with diabetic patients, Latino patients. That's why the name in Spanish. And we were able to reach previously not reachable patients. We were able to visit them home because social workers and other members of the healthcare team do not have the time to go that extra length and pay a longer visit in homes and make observations and notes. So the promotoras were able to do that. We're able to stay longer. We're able to educate on and provide the blood pressure monitors, teach them how to do texting so they can text back their daily measures and being supported virtually. And in terms of health outcomes, yes, they had an impact on blood pressure, on nutrition, and seeking other support care, like mental health support. And now I will talk more about one example here in San Diego that I've been working with the neighborhood navigator model. And that is a model that we integrate the Promotoras community health workers into an established community organization like mine, CVCC, Chula Vista Community Collaborative. And we have a network of 5 family resource centers. And we do direct service delivery of food, transportation cards, diapers, school uniforms, lice shampoo, everything to our families in need. And in this program, we were also included along with 2 other organizations in the San Diego County, which, if you know, is very broad. So the 3 organizations, we hired CHWs as care coordinators, and we linked with their insurance. We supervised and trained the staff. We provide support to the staff with ongoing education series and tangible items for them to assist the patients, all the way from walkers, gauzes for after hospital discharge, transportation cards for the children. We do provide that support because we work very closely with the other navigators and ensure that those numbers are met. And without further ado, I'll bring in one member of that group as a care navigator and promotora with many years of experience, and I'll leave Aida Mesa to share her personal story and before going into more detail about what she did in that neighborhood model.
Hi, everybody. Thank you for having me here. My name is Aida Mesa, and I am a promotora from the Community Collaborative, Chula Vista Community Collaborative. And I'm doing this for more than 20 years, working as a promotora. And as a care coordinator, I have like maybe 8 years doing this. So I'm going to tell you why I'm here right now. I came from Tijuana, Mexico. I born there. And I came here because my husband and my children, they are a US citizen. And my husband wanted our children to study here. So when we came here, I was in the home and I said, oh, I need to do something productive here. So I started as a volunteer in our children's school. One day, my oldest son had an emergency. He had an asthma attack and we took him to the hospital. They took very well care of my son and he got discharged the next day. But we had this problem. At that time, my husband decided to become self-employed. So we lost our health insurance. Somebody told us to go to a community clinic and ask for, do the application for medical. I didn't know nothing about that at that time. So I went over there and this was the worst day of my life. I'm sorry to say that, but it was the truth. The lady who was there attending the people there, she had a really bad attitude and I have this big problem with her. She just saw my document and in a minute she said that I don't qualify. I didn't qualify for medical. At that time, I asked her why, if she can explain me. And she said, she responded to, I don't qualify because we are making a lot of money. And I told her that if she review all my documentation, because I had my profit and loss statement. And she said, I'm seeing the gross and it's all I need to know about you. And you are not qualifying right now. And I remember when she told me a lot of people from Tijuana used to come and take advantage of the system. And I feel like a cold water in me at that time. And I said, okay, thank you so much. I got my children's and went back to my house. I was crying. I remember I feel frustrated, not knowing what to do, very bad. And I was living at that time, crossing the street from the school, from Vista Square School, and they have a family resource center at that time. They just beginning. And I went over there and I asked to speak with the family liaison that they have at that time. Really nice person. She helped me a lot and she made me feel different. She made me feel that I was important for somebody here and in this country, because I have here like 4 months, I think. We just came from TJ. So at that time, I started working with them as a volunteer. And a few months later, they asked me to work a part-time with them. I remember that I said no, because I felt that I wasn't prepared. I didn't know nothing. I didn't know English, nothing. The language is a barrier for me. Just right now, I can't pronounce it very well. But they said, yes, you can do it. And you are going to do it with Latin people, with Spanish speaker people. So you can bring them and let them know that we are here to help them. At that time, I promised myself that I'm going to work. It doesn't matter what organization is, but I want to work and do the best I can with the people that really need help. And I want to add something. At that time, I started going to school, and I went to school for health insurance. I became CAA California Certified Insurance because I really want to help the people. And I took these classes for taxes and small business and everything related with that. And I'm here now. Thank you for having me here.
Yes, and with that story, that leads it to where she is now. And she has been working with Care Navigator program, and she will share with you some of the activities that she has been able to do in support of patients.
Yes, thank you. We are doing outreach always. We started doing outreach and We have a tail list. They send it us from the health plan that we are working with. And we have all this personal information like date, date of birth, telephone number, current address, and the main health condition of the client. We make 10 attempts. I'm sorry, 5 attempts, 5 or 10. I usually call them like 10 times during this first visit, but it's 5 attempts, 3 calls. And if we can't reach them, we need to send an unable contact letter. And if we can't reach them with this letter, we need to go to make the another visit, unexpected visit. And sometimes we can reach them at that time, and we try to work with them, start the conversation, getting information. But if not, okay, we need to go back and yes, try another person, another client. And we try to, we have to do some assessment and data collection and documentation. So we have our database to enter all the information we collect from the client, every contact, changes, updates, notes, everything that everything that we have with the client. The HRA, that is a health risk assessment. This is the form to identify the client's risk. And then after we have all this information, we have the HAP, Health Action Plan. This is a plan to make to address all identified risks. And we have another space for case notes to identify how risk has been addressed, how we address this client, these problems, the needs that they have. We also use to have a file for each client to have a copy of all these documents that we have with them. And I just need to tell you that I'm very happy to do this because we have to be sincere with their clients, be honest with them. And if we do it, I always tell them that if I'm not the right person for them, they just need to tell me and we can send them another patient navigator. The most important for us is their well-being. So if they need to change, that's okay. It's not a problem, but I want them, I really want them to take advantage of our program and our services. Yeah.
And that's that personal touch that is important. That is not only provision of services at MT, but is based on relationships of trust, especially in hard times. And during COVID, there was a lot of mistrust and misinformation around. And because of those established relationships with navigators and promotores, we have been able to move forward in contacting, reaching, and supporting the families. Next, Aida will tell us more about some of the areas specifically that she has been able to assist in various areas. So tell us more.
Yes, we have the opportunity to help our clients in so many areas. One of the areas when they before the COVID, we have like more opportunity to contact them, to feel free to smile with them, make our first conversation very nice and offer them, they can see us and feel that that rapport with us. But after that, with the COVID, we have learned a lot of different things. We have to be more patient. We have to be more careful with the words that we use. We need to listen more, focus on more in what they said, what they are saying, what they really want. We need to use our critical thinking, and more than before, I found this, that today is very hard for us as a promotoras, as care coordinators, try to really identify the risk of the needs of the client, because we are not seeing to them. We are not, we don't have the eyes on it. The how do you say, Brenda Lee? This
That
communication, eye
and-
contact. Sorry, we don't have the eye contact, and this is more difficult for us to attend them. That's why I always tell them that our supervisors, it is not, if we need to do this in 20 minutes, we don't have a time to do it. Because when we come with a plan for them, sometimes they are not ready for that day. Sometimes they are not ready for this plan. So we need to change everything. We need to be there in the moment they need it and for the reason they need it, and try to resolve at that moment the need that they have. So I really love this job. And sometimes we can help them with something really simple things. I'm sorry, and sometimes we think that they really, this really change their lives. For example, transportation, dental, lenses, glasses, chronic diseases management, like sometimes nutrition at that time because they have diabetes and they level is too high. So we need to start sending in some information, but at the same time, education for them. And like sometimes we call them and they are fighting with the system. They don't have the medical at that time, so they can get access to the medication, or they don't know how to use it. We are there for them. We can explain them. We can help them with the forms for renewal, for any documentation that they need. Sometimes we read some letters, some documentation that they have, they send us. But as I told you before, it was really hard for us because we have been using the telephone, the text messages, the
WhatsApp.
yes, and also the voicemail, the everything that we can, letters, regular mail, everything we can do it to have that contact with our clients.
So Aida, share with us some of those impact stories, experiences with clients, and I think that you have one to share.
Yes, I'm sorry, and I need to read it because it's too long. Okay, this is the story of Maria. This is those are fictitious names. Maria is an 85 years old adult woman, widow, living with her daughter and son-in-law. Maria has Medicare and Medical as health insurance, and she is receiving $300 a month from Social Security. The first time the HAB team visited Maria at her home, everybody was sitting at the table. Maria's daughter, Maria's son-in-law, and we two members of the care navigators. As we were talking to them and having the information for the HRS, health risk assessment that we need, Maria's daughter stated that Maria has some chronic diseases such as diabetes, hypertension, and heart problems. Also, Maria told us that she had bone pain and anemia, and she has a doctor appointment the following week. Maria's daughter did mention that before, Maria used to go out shopping and take a walk in the parking lot of the trailer park where they live, but not anymore. Maria spent a long time in her room, and during the breakfast, her daughter called her a few times, but Maria says she's praying, and she's refusing to share the table with them. Like at 11 in the morning, at 11 o'clock, when nobody else is in the kitchen, Maria comes out to eat just something, not enough for her good nutrition. And after that, she comes back to her room. Obviously, we, the care coordinators, noticed that something was not right there, but it wasn't the right time to discover it. While Maria was not in danger, it was just the first visit. Okay. In the second home visit, I was there by myself, without co-worker. And I had the opportunity to ask Maria's daughter if I can speak just with Maria for a few minutes, and after that, I can speak with Maria. Maria's daughter accepted. Once Maria and I were alone, I let her know that I really want to help her. I really care about her. And half team really wanted to help. But in order to do that, we needed to know if she has any special reason to act like this. I did explain her, I did explain it to her how she was hurting herself without eating well and without enjoying her family. Also, how everything is related with her health, her chronic diseases, and everything about the health. Maria started opening her heart with me and saying that she felt very bad. It was not her home, that she did not belong there. She was only a hindrance to his daughter, and that she wanted to go from there anywhere, but she doesn't have any other place to live. I asked her permission to talk with her daughter and share what she had told me. She said yes. Once I started talking with Maria's daughter, I used it the same way, asking to her how she's feeling about that situation. And she started crying, the same. She said she loves her mother, but at that moment she was passing for a lot of problems, not having time for herself, for her husband, no good relation with her two sons that live in Los Angeles, and she was not receiving help from the other part of the family. And her mother also was acting like that, with attitude, not thinking on how her daughter was feeling, everything she needed to do for her, etc., etc., etc. I said so that I was very sorry to hear that. And that is the reason why I need to share something with her about her mother, that everything that her mother had told me. And because her mother was feeling the same way as her, that they just need to talk and support each other. Also, I mentioned some resources that maybe can help for their new beginning as a mother and daughter with a good communication, better relation, and supporting each other. She really liked that idea, Maria's daughter. Really liked that idea, and we all sat together in the and made a plan. The plan was, number one, Maria was going to start coming out in the morning and at 9 o'clock to share the table with the family. But she will try just the half of the plate, not everything. At noon, she will try to have a walk for a few minutes and go back to her room. Same with the food, just try and snack and return to her room. And maybe in the future, she can start going out to the market or visiting the family. Maria's daughter will try to be more patient with her mother, start having some time for herself, time with her husband, using some resources that I did provide them. At this time, I did provide some resources such as Southern Caregiver Resource Center. This is providing free classes for caregivers and support for them. In-home support services, and this is caregiver for some hours to help in the house for the patient. And Es Difícil Ser Mujer from Chula Vista CVCC, Mental Health for Maria's Daughter. This is a woman group where they can come and express themselves, and they can they can get advantage of the program, having a lot of information, and they can recognize the difference between sadness and depression. So,
Certainly. So that is a wonderful story,
yes.
because it has so many layers of assistance, of cultural and linguistic competence by members of the care team that made that possible. And I wanted to close this with some final thoughts, Aida. What would you like to share with the group?
Yes, I would like to say that I'm very happy to be here. I'm very happy to be a promotora. This is a job that have teach me a lot. It's not just for the community. It's not, this job is not for the community, for the other people, for the patient, but for me. for my personal life, because I became more patient. I became more, I can listen to my family. I can be more relaxed at the time of we have a hard times. I know all the resources I needed in case when I need it, when we have a hard time. But it's as the same for me is for the other person. And I really love my job. And I when I made the promise that I'm going to help the person that needed, I I really make the commitment with me, with this job, but with my person too. Thank you for having me here.
Thank you, Aida, for sharing that. And this is part of the role that the CSWs, because as you may not know, but the pay is not great. It's really a lot of capacity development, investment of time and energy, and their true self, because they themselves are patients and are caregivers, but also they help others find that voice, find ways to improve on their situation. And that's the power of patient voice that many healthcare organizations are trying to integrate. I recognizing as a valid area to invest time, energy, and resources to improve care delivery. And there's this wonderful, quick book that really talks about how the promotores, as part of teams in healthcare, can support patients in showing up for their visits, understanding and managing better their condition or disease, and adhering to those plans that I was talking to us about, and that knowledge being shared in medical table where all those care members of that team are present, are talking about this patient and their case, and definitely improving on their status. Here are some resources, and those are active links that I will share with you once the presentation is over. Libby and her team will be able to forward to you these slides for you to know more about this profession. There is a National Association of Community Health Workers. Their credential is a state by state matter. Where I came from Florida, we worked, me as a president of the Florida CSW Coalition, and we're able to institute a credential statewide. California has chosen, is still in the process of deciding whether they go or not through credentialing. But there are other states that have also mandatory credentialing, like Texas. And there is more. We are putting together a California CHW community of practice. And more, the link is also, will take you there and get to know more about our statewide efforts. So we really thank you for you being here. Aida, she accepted the invitation. I was very happy that she did, and share with you our story. And here for more information, you can find us online. And I will stop sharing the slides so we can actually get to see you and check out the chat.
Well, there's been an active chat, Brenda Lee and Aida. Thank you so much for sharing your experiences. Aida, it's just amazing work that you do, and so vitally important to the people that you're helping, and to the community health overall. I think you're getting to a lot of the things that healthcare systems trying to solve and to look at. So I think there's a lot of kudos in that chat box for you, Aida. So please make sure you you see that. But I think there's a little bit of conversation as well, Brenda Lee, around the sustainability of these programs. And you mentioned earlier that they're not highly paid, and they're the funding is sort of project dependent a bit. And so I was just thinking, and Ting was thinking about how have you seen some models, and I know John was mentioning a model too, but have you seen some models that are, you really help to sustain these programs?
Yes. So there are several, and California is actually a very active integrating CHWs, and they even post their public comment period for organizations to tell the stories and come together with some logistical answers with the Medicaid program. Health plans are taking a closer look and incorporating. That's why the Navigator program came actually from healthcare plans. We are even looking at specialty Navigator programs, so like a pediatric Navigator and or housing Navigator. So they're interconnected with those social determinants of health and health outcomes. Across the nation, there are several impact stories, either condition specific or system specific. We know the positive impact on health outcomes on asthma from projects in New York. In Pennsylvania, there is a Center for Community Health Workers that work with the VA system, among others. In Florida, we do a lot through interventions, federal funds that support creation of new knowledge through research. And that's a way to feed not only the knowledge and the capacity building, but also making the case with return on investment studies as well. Like there are several that mentioned that if for every dollar invested in a CHW intervention, there is a return on investment of 2. The patient-centered outcomes research is funding, it has been funding for the last 10 years since their inception, research interventions that include promotoras and community health workers. I invite you to take a look at www.pcori.org, and just in the search box you put community health workers, and it will show all the evidence-based research and engagement projects that they have done. So we are aiming for sustainability by collecting the data, by participating in those studies and sharing those cases. I see now in the chat even more comments, and definitely I would love to follow up on that. So if Libby's staff can then capture that chat and forward that with those contact information. I see a lot with the Rated Children's System and other entities.
And there's a question in here, Brenda Lee, can CHWs attend medical visits?
And that is depending on the group. I know that Aida was working. Could you tell us more about where you, as a care navigator, participated in medical visits?
Yes, I'm working with the HUB program. This is health risk. I'm sorry, I forgot the HUB program. I'm sorry, that initial. Yes, I'm sorry because I'm pretty nervous. Yes, I'm working with person that has chronic diseases, and that they need, sometimes they are in the hospital and they need more more attention from our team, because in my case it's a person that they have chronic diseases, as heart problems, they are in dialysis, they have asthma attacks, and they are visiting the ER for several times during the year. So yes, we have to help them with the following appointment with the doctor, with everything that they need when they got discharged from the hospital, in order to everything follow. everything is okay with them, to check if they are seeing the doctor, if they are taking the medications, if they have another appointment, if they need a specialist, all these problems that they used to have.
And depending on the family and the patient, they may authorize that patient navigator attend the doctor's visit and serve even maybe as, depending on the skills, as translators. So that is something that it includes not only their life with the doctor, but also outside after kind of translating the discharge instructions into in clear communication for that family and that patient.
I'm sorry, is the high utilizer program. So sorry for that.
Right.
Great, thank you.
We're not clicking on the labels. It's like what you do.
Yes, exactly. Exactly. You're speaking beautifully to the function of your job, and that's the important part. So you know what your presentation today has done for me is to really make me think more broadly about community health worker programs, because I think in my mind, I always went to Promotores programs and have seen the benefit of those in early childhood years and across. And so, but what you're talking about, what you just described, Brenda Lee, is more, it's really expanding into supporting disease specific. And I even recently saw on LinkedIn a gentleman, Henry Black, who is running a certification program in a high school in Sacramento. So really raising the younger generation even. So I really am impressed with the breadth of this role.
And we have many cases, and we celebrate it, on events that a mother and daughter have joined, and the daughter has kind of grown up throughout the years, seeing the mother as a role model, and then it follows the steps. So I know that we have in our Adelante Promotores conference highlighted those cases because it just warms our heart. And we had those examples in Florida where I came from too. Because it's a vocation, and we should support that as a job with credentialing, respect for that profession, and pathways for capacity building, training, and better pay and sustainable job security.
Absolutely. The value statement, is there. So bringing all those pieces together, absolutely. And it's just, speaking of which, there's another question in the chat box. Is the CHW's time allowed to be captured as part of the chronic disease management program of CMS?
And see, I know of CDC's work with Betsy Rodriguez, that her education, the diabetes educators. So even if a certified diabetes educator is managing a program and has the Promotores support, because it's supervised, is actually reimbursable for that organization. So there are many ways that, again, the label may not fit and say community health worker, but the person doing that role has to fit into an organizational structure, right? And it may be called something different to fit that organizational structure, job classification, but is doing that role. And therefore, we are proposing more and more integration with those established programs, that you don't have necessarily have to have everybody being a master's degree level or higher clinical, as long as they can supervise somebody that, as a promoter or community health worker, is properly trained, supervised, and supported to do those services.
That makes perfect sense. Healthcare is a team sport, right? We need all players, all abilities, all levels. That's really great. All right. Any other questions or comments? And feel free to come off mute and ask a question if you'd like, or a comment. I know we have John Shaw with us today, who's quite a passionate proponent of community health worker programs. John, I didn't know if you had a comment.
I do. Can't be long. I got another call at 4, but community health workers are such an under-realized asset to our whole healthcare system, and shed some light on it. We undervalue them tremendously. We're making great strides in starting to recognize that. There's a project called C3 that came up with roles and tasks for CHWs to have national standards. Brenda Lee mentioned that there's a national CHW organization as well as the APHA special group. The problem is that you don't quite fit and you're sort of in between social and medical. And so we're trying to get people to more recognize the need for that translation, not just in language, but in concept between social care and healthcare. Good note is that there's a huge focus on health equity going forward. The National Quality Forum just had their 3-day annual meeting this week, and much of the discussion was of addressing health equity, and the ideal people to address health equity are CHWs.
So my slide at the beginning was equity.
Yeah, and so that's one of my goals, is to try to move the policy forward. And Libby's been great in that effort as well, much more so than I can be. But Brenda Lee, I'll reach out to you because I'm a snowbird, not only in Albany, but also down in Florida. And I'm on the Tampa Bay Health Collaborative, and we're trying to find how better to do things down there. Maybe you have some ideas, but this is all important. This is a way to get patient, family, and carer voice into policy and funding. The return on investment is what has been the issue. And if CHWs are successful in getting people to avoid the need for emergency rooms and hospitalization, that means less money for hospitals. So having a Medicaid program or new payment plans or the health plans themselves get involved in supporting that is probably what we're going to see, because the savings, that 2-to-1 savings on return on investment, the money that's saved goes to the health plan or goes to Medi-Cal or Medicaid. So they're the ones that should be funding all of this, right?
Correct. I agree with you, John, and I'm on board and so appreciate the passion with which you advocate for this, because I think it's really going to take multiple voices across multiple stakeholder groups to get this work really sustained in the fabric of our healthcare in America. So I just want to end, and thank you so much for taking time, John, to join us today. We'll continue this conversation. Definitely. There's a lot of passion around it on this call today. So we'll be in touch and follow up. But I want to end today, Brenda Lee and Aida. We had a question from Dorothy early on to ask, and I think we've got a fair number of folks on the line who are interested. If I wanted to become a CHW, how would I do that? Where would I start?
Certainly the path, there are many paths to it. Some begin with their volunteer work, some others immediately jump into it as a profession. Each state has credentialing requirements or do not have set up credentialing systems. California, as I indicated earlier, doesn't have a statewide, but many programs run their own academies and their own trainings. I see Lisa Hamilton as one of the attendees today, and she was with me, co-president of the Florida CHW Coalition, in which we worked with partners to develop a statewide, and we based our work and we did it in alignment with that C3 national standard publication and effort that John Snow talked to you about earlier. So each state may even have, or even region, because like Texas has many regions, you can find online either an association, a coalition, or a community of practice group that can guide you in your local process. There might be some education courses that you can start accruing online on a diverse topics, but as the basic core competencies across programs that I've seen in the United States involve communication skills, education skills, safety and confidentiality of data, content specific, given conditions and health and diseases, information, also local resources, and the social determinants of health, foundations of health, like those basic principles of nutrition, physical activity, and how you can take part, an active part in your health and managing your diseases. So those are core competencies that go across, and they get different numbers of credit hours in any particular given program. Definitely the expanded role of CHWs that I'm proposing as care navigators and part of research teams include some basics on research. And you can see in pcori.org the training that I have put together for CHWs in research, so they're better and well-versed in data collecting, tracking, and data management systems, so they will be part of research teams. So there are many pathways. We do want to acknowledge that there are some CHWs and promotores that want to give it a go just as volunteers after church on Sunday, some hours, but there are others that really clearly see this as a path for professional development.
Well, thank you so much, Brenda Lee. I really appreciate that. Brenda Lee and Aida, thank you again for your really robust and comprehensive presentation. Sorry about the saw in the background. We will follow up with everybody who has registered for the call with a recording, the slide deck, and also several of the resources that Brenda Lee mentioned. So again, thank you so much. Join us again next month for our next monthly workshop. And in the meantime, have a wonderful weekend. Take care, everybody.
Bye.